So the difference is between this big barrel and this small thing here. This is what is the evolution of how to do veno-venous ECMO in 40 years. Actually, almost 50, 71 to 2017 is 47 years. ECMO is very powerful. It's one of the most powerful devices we can use. It's very invasive. You have to put big cannulas into big vessels to achieve high blood flow. If you want to oxygenate, you need liters of blood flow per minute, 3 to 4, sometimes 5 liters per minute. If you open the tap in your bathtub, you do not get 5 liters per minute. So it's a very high flow. You exsanguinate a patient in 40 seconds. It's complex technology. It requires a specialized environment. Most of the times, veno-venous ECMO is targeted to avoid hypoxic death. Up to these days, ECMO is a rescue procedure. I will discuss with you not the indications, but the target probably. Blood is drained from a central vein, normally inferior vena cava, pumped through an oxygenator back to the vein. And it does not support hemodynamics, though it might affect it, but it does not support hemodynamics. It does not change cardiac output directly. Now, the question is, why do we do veno-venous bypasses instead of veno-arterial? ECMO started veno-arterial, but now we only do veno-venous mostly. There are specific indications for veno-arterial, but I will not discuss them. What is good in oxygenating venous blood? Well, if you put a patient in ECMO, it's because the intrapulmonary shunt is very high. The amount of blood that crosses the lung without getting oxygenated is very high. Here, you see a 50% shunt patient. Half of the blood flow crosses the lung without getting oxygenated. If your mixed venous saturation is 50%, you have 50% of the blood that comes out of the lung equal to the mixed venous, 50% saturated. The other 1/2 is fully oxygenated. So the average between 50% and 100% makes 75% saturated. Means that the arterial PO2 is 40 millimeters of mercury. Your patient is severely hypoxic, shunt is 50%. Now, ECMO oxygenates venous blood, and the venous blood goes from 50% to 75%. Now you mix 75% blood with 100% oxygenated blood. And now your artery is 87.5% oxygenated. PO2 is 58, and your patient is no longer severely hypoxic. Why? Because you have raised mixed venous oxygenation. The level of mixed venous oxygenation is the most important determinant of the effect of veno-venous ECMO. Now, why don't we use ECMO in everybody? Well, these are the data from the very successful Australian H1N1 ECMO project. Our colleagues did ECMO in severe ARDS caused by H1N1 pandemic in 2009. And survival was very high, 79% survival. They had 14 deaths out of 68 patients. Those deaths, more than 50% of those deaths were due to hemorrhagic complications, 6 of whom were intracranial. They had almost 80% survival, and more than 1/2 of the death rate was due to complications of ECMO. So you better not use veno-venous ECMO in patients that do not need it. ECMO is a complicated technique, but we will not be talking about techniques today. What I care about is how to handle the patient's lung, because what we want is not to take care of the machine, we want to take care of the patient. ECMO is designed to allow the lung to heal, to put the patient's lung in a situation that favors healing, that minimizes ventilator-induced lung injury. What we do when we start veno-venous ECMO is that we maintain mean airway pressure at the same level we had before connection, and then we decrease it progressively. We use low-frequency ventilation. We lower the tidal volume. We decrease the IE ratio. We'll discuss recruitment. Oxygenation, we'll talk about it. When we started ECMO in 1979, we exploited the capability of the membrane lung to remove CO2, to decrease ventilatory rate. And we used a rate between 2 to 5 breaths per minute, and claimed that low frequency was protective for the lung. This was 1980. What is being done these days with the patient's lung? This is a survey done by Professor Serpaneto in Germany. And you see here, in red, survivors, in blue, non-survivors, which is an euphemism to say dead patients, patients who died. Now, you see that tidal volume is decreased down from 6 to 4 milliliters per kilo. So almost everybody decreases tidal volume, because tidal volume is the highest determinant of ventilator-induced lung injury. PEEP stays between 10 and 15, and plateau pressure goes down from 30 to 22, 23 centimeters of water. So you see that the rules to decrease ventilator-induced lung injury risk are followed, except for rate. The rate, ventilatory rate, stays around between 15 and 20. Because apparently we do not pay attention to the risk of rate. If we breathe 10 times per minute, the risk of ventilator-induced lung injury is higher than if we breathe 5 times per minute. It's intuitive, but is physics. And actually, we do not need such high respiratory rates, except if we have a low PEEP and we want to maintain lung recruitment. In the old times, we used high tidal volumes because high tidal volumes improved oxygenation. and high tidal volumes improved oxygenation because they maintained an inflated lung. Unfortunately, that was the mechanism to generate ventilator-induced lung injury. Now, when we have a patient with a RDS, we try to recruit the lung, because recruiting the lung means improving oxygenation. But do we know whether a recruited lung heals better and faster than a non-recruited lung? Is it true that atelectasis favors infections? When we have, this is an old slide from Ted Colobor, and you see that when we have a patient with pneumonia, we do not intubate the pneumonia lobe to recruit it. Does anybody intubate a lobe when it has pneumonia? No. But if pneumonia is diffuse to 3 or 4 lobes, then we have to intubate the patient. Actually, most pneumonia heal without recruitment. And most ARDS patients do have pneumonia anyway. I like to see my patients with a recruited lung rather than with a collapsed lung. But not everybody does that. And since the doubt is the stem of progress, I show you what our colleagues in Stockholm do. These are from the group of Palle Palmer in Stockholm at the Karolinska. And on your left-hand side, you see the pressures before connection and after connection to bypass. And you see that airway pressure, mean airway pressure, goes down from 25 to around 10. Connection to ECMO allows these colleagues to decrease mean airway pressure from 25 to 10. Pressure is the major determinant of ventilator-induced lung injury. But now, look at oxygenation. Before connection, saturation, arterial saturation was 86%. After connection, saturation is 82%. Wow. They connected patients to ECMO, extracorporal membrane oxygenation, and the oxygenation gets lower. Are they crazy? Perhaps a bit, but not entirely. 82 of saturation, patients can live with. But they have such a decent saturation, having decreased PEEP down to 5, mean airway pressure down to 10, peak airway pressure to lower than 20. So they have minimized the ventilator-induced lung injury, maintaining a vital oxygenation. This patient could not be alive with such a low pressures unless he was on ECMO. Last point is about spontaneous breathing in ECMO. Spontaneous breathing in ECMO in ARDS patients in the acute phase is almost impossible. In this paper from the group of Gattinoni and Croti in Milan, out of 30 patients with ARDS, only 8 could be extubated during the first week. And of those 8, 4 got re-intubated during ECMO. And that is because early severe ARDS patients in the early phase have a very high respiratory drive, and we cannot suppress it except when we use paralytics or extremely heavy sedation. You see, these patients in ECMO, in spite of being in ECMO, with CO2 removed by the machine, he has 30 centimeters of water, esophageal pressure swings. Very strong drive. If we let him if we let him breathe like that, he will injure his own lungs. When the patient recovers, then we recover the ability to control respiratory rate by removing CO2. But in the early phase, the drive is not controlled by blood gases. It's there because the lung is diseased. I think my time is finished, right? So ECMO is not a quick procedure. It takes days, weeks, sometimes months. And in our experience, the average time to recover spontaneous breathing in ECMO is 18 days. And by that, I think that I finish here. The only thing I want to show you is that ECMO is a rare procedure. It should be used in selected patients and not in every center. The right way to do it is to build a network with a referral of patients in specialized centers. A center should be doing at least 20 patients per year. So we should not do what is being done as an example in Germany, where 100 of centers of ECMO are flourishing, and probably the indications are not very strict. I finish here. Thank you very much.